An 82-year-old male presents with a subacute cough and progressive exertional shortness of breath. His chest radiograph shows persistent bilateral lower lung zone consolidations. I am showing you an axial chest computed tomography scan. Describe the findings.
The chest computed tomography scan demonstrates geographic areas of airspace consolidation in the dependent posterior regions of both lower lobes. Within these areas of consolidation, there are focal zones of very low attenuation, measuring between -50 and -100 Hounsfield units, which is in the density range of fat. There is also a superimposed crazy paving pattern in the adjacent lung parenchyma.
Based on these imaging findings, what is your primary diagnosis and the pathognomonic computed tomography sign?
The primary diagnosis is exogenous lipoid pneumonia. The pathognomonic sign is the presence of fat density, with Hounsfield units in the -50 to -150 range, within the areas of consolidation.
If I tell you the patient has a history of advanced Parkinson's disease and chronic constipation, how does this clinical history support and explain the diagnosis?
Patients with Parkinson's disease frequently have swallowing dysfunction, placing them at high risk for aspiration. The chronic constipation suggests they may be using mineral oil or liquid paraffin as a laxative. The accidental microaspiration of this oil-based laxative directly leads to lipoid pneumonia.
What are the common substances implicated in exogenous lipoid pneumonia?
The most common substances are mineral oil or liquid paraffin used as laxatives, oil-based nasal drops, and petroleum jelly applied to the nares.
Name 4 other causes of chronic airspace consolidation on chest imaging.
The differentials for chronic consolidation include lipidic adenocarcinoma, pulmonary lymphoma, pulmonary alveolar proteinosis, and organizing pneumonia.
How does lipoid pneumonia differ, radiologically, from these other causes of chronic consolidation?
Lipoid pneumonia is the only entity characterized by fat attenuation within the consolidation on computed tomography, and it typically shows a dependent, basilar distribution.
Explain the typical histological findings of exogenous lipoid pneumonia.
Histologically, the alveoli are filled with lipid-laden macrophages and large lipid droplets. This induces a foreign body giant cell reaction, alveolar wall thickening, and progressive interstitial fibrosis.
Contrast exogenous lipoid pneumonia with endogenous lipoid pneumonia.
Exogenous lipoid pneumonia is caused by inhaled or aspirated oils. Endogenous, or cholesterol, pneumonia is a post-obstructive process distal to a bronchial tumor, where cell membrane breakdown releases cholesterol that is phagocytosed by macrophages.
What is a major diagnostic pitfall associated with lipoid pneumonia on chest computed tomography?
Lipoid pneumonia can present as a focal, spiculated mass, like consolidation, that mimics bronchogenic carcinoma. If the internal fat density is not carefully measured on computed tomography, it may lead to an unnecessary lobectomy.
State the critical safety warnings and management recommendations for this patient.
The critical safety warnings are progressive lung fibrosis from continued aspiration and misdiagnosis of the mass like form as malignancy. Radiologists must immediately recommend discontinuing all oil-based substances, suggest a formal swallowing assessment by speech and language therapy, and advise clinical follow-up to confirm resolution. Refer to pulmonary medicine